So welcome to today's webinar resident series, The Circle of Digital Dentistry, Acquisition, Fabrication, and Insertion. It is being presented by Kelly Bevington, RDA, EFDA. Now it is my pleasure to introduce the Adam Dreyfus, Director of University, Government, and Institutions. Take it away, Adam.
Oh, good morning, Jessica, and thank you so much for that warm welcome. But with that being said, as I always say, NDX, myself, the education team, Jessica, Kelly Bevington, who is part of our team, we're here for you today, tomorrow, and for the future. But I am so excited to have Kelly present today. And I really want you all to take in this information. But as my tagline says, today, tomorrow, and for the future, Kelly is really today, tomorrow, and the future, and here to support you through your endeavors in this industry. Without further ado, Kelly, please take it away.
Thanks so much. Really appreciate it, Adam. Let me share my screen here. All right, so today we are going to be talking about digital dentistry, right? The title, The Circle of Digital Dentistry, acquisition, right? Acquiring the data, the digital impressions, fabrication, educating you a little bit upon how the lab fabricates restorations for you, and then insertion. So let's move forward. If you have any particular questions, please feel free to pop them into the Q&A or the chat, and we will either address them as we go along or at the conclusion of the presentation. So a little bit about me. I am a RDA EFTA by original training, a dental professional of more than 30 years, and have had the good fortune of starting my career in Southern California, worked for a great Navy dentist, then shifted coast and went up to New Haven, Connecticut, where I was in private practice with an amazing AACD doctor, the second female AACD accredited member way back in the late 80s. And then private practice in my home state of Pennsylvania, where I reside now. And he was the inventor of the triple tray. So really cool experiences in private practice. And then I shifted to the laboratory space just about 30 years ago. So I always like to do a fun fact, right? People work with people. I want you to get to know me a little bit. My husband and I just celebrated 40 years of marriage together. I married the boy next door. And the fun fact on this slide is that when I came to look at our home for the first time by myself, I could sense that there was something further in the basement than what I could really see. Old house built early 1900. There was a dental lab in my basement. Yep. I walked in, saw the wax spatula, little Bunsen burner, before cell phones. So I had to go and call my husband right away. I'm like, this is it. It's an omen. There's a dental lab in the basement, right? So I love dentistry. I hope you can tell that. And I really love digital. So I started into digital aspects almost 20 years ago with the original iTero that was manufactured by Cadent. So please think of NDX, the iOS team, as a resource for you. We have lots of different formats of education. Of course, we have presentations like today, right? Different webinars. There are recorded webinars on our website, but we also have podcasts. We have articles that we've written, and we have documents that we're able to provide to you as well. So this is myself and our iOS clinical training team. We're able to provide support across the country. So we have a designated person for the East. That's pretty much me. Brittany Carey is a registered dental hygienist. She covers the West. And then Brenda Kirkin supports the Midwest. And again, all formally trained, well experienced, 20 plus years in the dental private practice space. So let's move on to digital. What are some reasons that we shift from analog to digital? And I want to make something really clear. I know I'm speaking to residents. It is critically important that you learn and understand clearly the analog world prior to moving into digital, or at least in conjunction with. I think it's really important that everybody has that baseline knowledge and that we understand the history of our profession before we can successfully move into the future of our profession. So a few reasons why doctors have chosen to go digital over the last 20 years. It improves accuracy. There's documentation that it improves accuracy if it's a good impression, right? So it needs to be a clear, good impression for it to improve the accuracy. I've been working chairside in operatory with patients for, again, 20 years. I can't tell you how many patients so much enjoy the impression taking process when it's digital versus analog. Most patients have, by the time I see them, have already had a wet impression taken, a PVS or an alginate impression. And so they know what that is. They have an expectation of that. And then we utilize the digital impression to not only acquire the data, right, to take the impression, but to educate them as well. And what a huge difference that makes. So along with that accuracy, the remakes, right, redos of any types of restorations are also decreased. And so that's something that we measure regularly here at the laboratory. And of course, as a lab, we want to see less remakes, as do the dentists. So very, very happy about that. Now, the saving on overhead, right, impression materials and so forth, and saving on chair time is a real thing. It's a real tangible item. It's dollars, right? So it's your potential revenue. It comes in time. So it's not like the first time you take a digital impression, is it going to save you chair time? Because you haven't become proficient at it yet. But once you do, it will reduce the time taking the impression. And then, of course, you're not using your traditional PVS impressions. Now, let's talk about that timeline. What does that look like? For some people, especially younger people who have grown up with, athletes often say, oh, I've got great hand-eye coordination. Well, good for you. This is a little bit different. You need hand-eye screen coordination. And most young people have that. They've grown up with screens, right? They've never not had a screen. Unlike me, who, I learned how to type on an IBM typewriter. So computer technology was not intrinsic to my being. That was something I had to learn. So when I am working with faculty members, when I'm working with dentists who are, late 40s and older, there's more of a learning curve. And that's okay. Not everybody has that great hand-eye screen coordination. So please don't feel badly if it doesn't come immediately to you. I love this slide because when we first started doing digital impressions, I could say that we could scan for a crown, a fixed crown, right? Or orthodontics. That was pretty much it. Maybe a bite splint if our scan was really good, if it was like Invisalign level quality. Today, there is truly not a dental prosthesis that we can't take a digital impression for. So how exciting is that, right? So we're doing crowns, bridges, veneers. We can get to that level of detail and intricacy needed for implant crowns and abutments. Removables, woo! I mean, the last 18 months with partials and dentures has been so exciting because it's not particularly an exciting arena of dentistry for most of us. And the headway that digital impressions has made has been amazing. All of the manufacturing companies today are working diligently to be able to have their device scan the fully edentulous intraoral cavity. Like they're trying hard, and that was not the case 5 years ago. So both Align Technologies and Medit are launching and will have something on market that is FDA approved to scan the fully edentulous intraoral cavity quickly and efficiently by year end. Trios is, in my opinion, already there. So super excited for that. So what else can we scan for? Surgical guides, bite splints, ortho, and of course, sleep appliances. So that's pretty much covers the gamut. I haven't really come into an experience where we were not successfully able to scan. So let's talk a little bit about why people, or the best way to incorporate digital technology into your practice, your clinic, your business. It is technology driven, right? It is technology. So in most cases, in today's practices and in today's dental schools, you find other technology, right? Everybody has digital charts now. Everybody has digital radiographs now. So it makes sense to incorporate analog impressions into digital to accommodate that technology-driven industry that we are now in, the profession that we're now in, because so many other things are no longer analog. It's the same thing with impressions. And I do encourage everyone that, has an opportunity to be part of the decision-making process as to what device to incorporate into your practice or clinic or school, wherever you end up after your residency program, to please experience a demonstration. It's really important. Not all digital scanners are the same. I say this routinely. Some people are, very off the cuff. Oh, well, a scan is a scan. They're all the same. They're not. I'm just telling you, I work with at least 6 different scanners routinely, and they all have their pros and cons. So when available, please accept the offer and opportunity to experience a demonstration. So NDX truly receives thousands of scans every day from across the country. And so think of us as a knowledge base of experience when it comes to all of these different devices. And I just popped some up on the slide, and there's more coming out every day. I mean, truly, there's quite a few coming from Korea right now. So I'm really interested to see what their platforms are going to look like. But the ones to the left-hand side of your screen are sort of tried and true, right? It's iTero by Align Technologies. We've got Trios, 3Shape is a manufacturer there. We've got Medit, we've got PrimeScan, been around a long time, great reputation from Dentsply Sirona. And then Dexis is part of Carestream. Emerald is part of Plan Mecca. Dexis and Emerald are quite popular within the dental academia, I find. They talk well, they communicate well with CBCT scans and other design platforms specifically for implants. And if that's something that's important to you, I would say 2 really excellent sources out there. And then we've got 3Disc, Virtual Vivo, and Telescan, Oral Scan. There's again, more and more coming out every day. So a couple slides, like what do they look like, right? So this is the standard iTero 5D. It has something called NIRI. It allows you to, when you're scanning, you can actually see decay as well. Trios has that as well. This is a standard cart. Trios, they have a Trios move, but I don't think that's something that they're really focusing on. Most scanner companies today are looking for a footprint that allows you as the user to sort of design it yourself. So you could have a laptop with a device, right? Just a wand. It may be corded or it may be wireless, battery operated. I grew up with cords, so I'm fine using a corded wand. The flexibility of a battery operated one is great, but you need to pay very, very close attention to the battery life. Because nothing, trust me, when I tell you nothing's worse than being in the middle of a scan and your battery dies quicker than you were anticipating. And sometimes you lose that data if you were in the middle of a scan. So something to keep in mind. So you can either have a laptop and a scanner device on a cart on wheels and move it from operatory to operatory, or in some cases, you may have a system built into place where you have a screen and a CPU in each operatory that runs the software from the scanner as well. Prime Scan is primarily, I'm not going to say never. They do have some laptop versions available, but most likely you would see it in a cart form. Really nice big screen. Pretty easy to manipulate the touchpad itself, and really takes a beautiful scan. And then we've got Medit. Medit is very similar to Trios as far as their laptop cart kind of footprint on that. Same thing with 3Dis. So just a couple of those. And I do want to mention that when taking an intraoral scan, I can't tell you how many practices I go into, and I think they miss the boat a little bit. They miss the potential opportunity on educating your patients. Yes, you already have radiographs. Yes, you might already have a study model. You may also have an intraoral camera where you'll take a photograph of like a tooth to show your patient perhaps a cracked amalgam or a broken cusp. But when you're able to show the patient their upper arch, their lower arch of dentition, and it makes more sense to them. They can see, okay, so those are my front teeth, those are my back teeth, those are my top teeth, those are my bottom teeth. And I like to share the story of my husband who went to a new dentist. The new dentist has an intraoral scanner, and they first take a scan of his teeth. Then they do the hygiene appointment. Then the doctor comes back in to review his radiographs, the communication from the hygienist, and the intraoral scan. And they show him his first molar, number 14. Can you see this dark area, Mr. Bevington? He says, yes, that's an amalgam filling. Can you see the black line through this amalgam filling? He says, yes. They explain it's a fracture and that every time he's biting, it's sort of pushing that tooth apart. Recommended a crown to be done on the tooth to sort of hold the tooth together. And he scheduled that crown that day and said to them, my old dentist has been telling me for a couple years that I needed a crown on that tooth. But if it's not broke, like, why fix it? Is my mentality, he tells them. But he could see it. It then made sense to him. So please keep that in mind when incorporating an intraoral scanner into your processes and protocols in your dental practice. It's not just for before and after pictures for ortho. It's not just to take a scan for a crown or a denture. It's an education tool to increase the knowledge base of your patients so that they understand their oral health and can make educated decisions about where to go with their health based on what you had to tell them, right? So let's get back into the laboratory part of it, right? So traditional impressions, analog workflow is our top line, right? There's more. What I like about this slide is it sort of shows you that there is more opportunity for potential human error that can occur when mixing stone, mixing plaster. Makes a huge difference when we're printing models, and we now can scan the analog impression and take it directly into a digital workflow from the lab. So that's something that we do now on a routine basis. And then the digital laboratory workflow is all digital, right? Everything is done from a computer, from accepting the file to managing and sort of cleaning up the digital models, if you will, to then putting it into design software and then into a mill or print in order to fabricate your prostheses. So it's really super cool. The scan file is really important. And it's important for you to review your scan in a monochromatic view or a stone model view. Every scanner out there has that capability. As a matter of fact, oftentimes you have the capability to not only view it in monochrome, but to scan in monochrome. Now, personally, I prefer to scan in color. As a dental professional, it makes more sense to me when I'm scanning and I'm looking at the screen to see the difference between gingival tissue, enamel, and dentin. Like that's what my eye is accustomed to. So I'm not suggesting that you should scan in monochrome, but you need to look at it, specifically preparations of crowns and bridges, to ensure that you can still see your margin 360 degrees. If for some reason you cannot, you need to go back in and rescan the area. And you may need to, readdress your gingival retraction or isolation in order to capture that, or in some cases, your preparation as well. So all intraoral scanners, although highly accurate, right, do provide you an opportunity to mark your own margin if you're so inclined. Now, I'm not going to suggest that you should mark your own margin. I take this philosophy, and remember, I've been in the industry for a long time. So there were dentists many moons ago, not too many left out there now, that would take an analog impression, send it to the lab, ask the lab to pour and articulate that model, send it back to the doctor to trim their own dies. That was a thing, a routine thing, especially with prosthodontists that wanted the precise control over their margins. And today, in the digital world, you do have that capability to mark your margins digitally, if that's something that you're inclined to do or that you feel you need to do because it was difficult for you to see your margins on the screen. Surely it's going to be difficult for the lab to see them. However, if you can sufficiently see your margin 360 degrees, I would not recommend marking your own margins unless you're super proficient at it. And that takes time to become proficient at it. Oftentimes you need a mouse to effectively do it, and many scanners do not, although you can attach a mouse to it. Many scanners do not come set up that way. And it would be an additional step for you to do it like on the screen is a little bit challenging for most people, even with a stylist. So if you can see your margins, I'm sure the lab can see them, any lab, and allow them to do what they do every day, all day long. They mark margins. And so that's my suggestion on that one. So a little bit on the workflow, right? So it comes from your scanner through an iOS portal, if you will, and those are raw scans, at which time it's then going to shift into design, where we will confirm the accuracy of the byte registration as well, and then go into the fine-tune part of marking your margins. So most technicians today are very familiar with intraoral scanning and different devices on the market, and they certainly lean on us to help them with that education and build that knowledge base as new things continue to come out. Most scans can be, cleaned up somewhat within different software that the laboratory has. However, you want to make sure that you are following your scan path protocols based on the individual scanner that you have. And I think iTero and Trios actually do a really good job of educating their doctors on, just because you see X on your scanner screen, on your computer screen, does not mean that that's what the lab is going to see when they receive it. When that raw file data comes into place, sometimes it can be very jumbled together. Sometimes the occlusion of the upper and lower arches are completely apart versus in sync, as you saw it on your screen. And that's a raw data software item. And although we have software to optimize it, sometimes it is not perfect. And in those cases, oftentimes myself or one of my colleagues on our team can remotely access your scanner and take a look at some different things and different ways perhaps to even submit the case to the lab to provide a better incoming result. Now, the CAD department, computer aided design, I just think it's amazing. It, like, everything is being done digitally, and they are creating even the most fine-tuned increase of a cuff tip or cosmetic cases, and adding a little mamelon on a anterior veneer case. It's really, truly amazing to watch it in work. If you have the opportunity to see it, I would encourage you to do so. And then the CAM part, right, is the manufacturing. And so at NDX, our laboratories have multiple different machines that, once the case is designed, it's going to go into some sort of milling or printing, if not both. So the models might be printed, and then the full contour zirconia, for instance, would be milled. And this is the image here to the far left. That's a puck, and there might be 10, 12, or more individual crowns on that puck that are all being milled at the same time. It's really pretty cool to see. And then there's lots of different types of mills and lots of different types of printing, and I'm not going to go into all the minutia of that because every lab is a little bit different as far as how they have that set up based on what type of restorations they are typically fabricating. And so milling can be done with a multitude of different materials as well. And then it is also going to be more traditionally fired, if you will, in an oven where sintering and final glaze and so forth occurs. And then, as we always do, whether it be analog or digital, we are then going to do our final quality control and make certain that what we see in that case pan matches what your prescription was, right? What you are specifically asking for. And that anatomy, margins, aesthetics, shade, all the basics are covered as well. Okay, so let's talk a little bit about how do you acquire the best digital impression that you can. And this sort of goes for analog as well. So what I hear frequently from doctors who are new to digital is that they rely on their polyvinyl siloxane material to that light body that they express around the prep itself to flow into the sulcus and capture the margin. So they're not so concerned about retraction cord, retraction paste, laser, like any kind of method to expose the margin, or really keeping the area dry and free of blood and saliva. With digital, it's a little different. You don't have a physical impression material pushing the gingival tissue out of the way. So proper isolation is going to be required, and that could be retraction cord. It could be proper isolation, meaning keeping the area dry. That could be something like isolite using four-handed dentistry, and the assistant is suctioning. It could be dry angles. It could be cotton rolls or 2x2 gauze. I'm typically not a fan of cotton rolls, as sometimes the fiber from the cotton rolls can be captured in the scan and cause distortion that it is not a good thing to experience. As well as if you have the cotton roll in the buccal vestibule, when you rotate your scanner buccally, it can be in the way and you're unable to capture the data that you need. The next thing is going to be complete acquisition of critical data, meaning the prep itself, the occlusal surfaces of the teeth. At least 70% of the buccal surfaces are going to be required for an accurate bite registration to allow the maxillary and mandibular arches to merge together. If there are any substantial holes or missing data in those areas, that's not good enough, right? So we need to make sure that the data is completely acquired. And then the margin on crowns and bridges is critically important, right? That's the foundation of what you're doing. The prep has to be scanned from all angles. So although you can oftentimes, if this is my tooth and this is my scanner, you can oftentimes sort of see the whole prep just from the occlusal surface. That is not sufficient. You need to rotate your wand and rotate buccally to 90 degrees and rotate lingually to 90 degrees, and then come back to the occlusal. And the reason that's important is when you're at the buccal and lingual positioning, you're sort of capturing all of the nooks and crannies and line angles of your prep. When you just capture it from the occlusal, it will be distorted. More times than not, you will experience a crown with an open margin is what we see on our end. Again, I mentioned earlier about using us as a resource. This is a document that we have to sort of give you some step-by-step little tips and pearls, if you will, on different devices that have worked really well in our hands. Now, in regards to your preparations are going to be super important. You want to have a prep that is typically a shoulder or a chamfer. It is the easiest for the laboratory to see a very distinctive margin. Unlike a knife edge, let's say, or a disappearing feather just sub G. Yeah, that's really challenging for the scanner to pick up. Now, if you've lasered the tissue or you've placed cord to create not only lateral retraction, but apical retraction. And the scanner can pick up the data and you can see your finish line of that feather, then yes, you could still use it. Yes, it's challenging, right? It's challenging. So it's easier for you to acquire. And there is evidence that a chamfer or shoulder margin will create a longer lasting, let's say, full contour zirconia. Now, if you're doing all gold or something, that's a different story. The feather or knife edge preparation can be adequate for that. A little bit of isolation, right? How can we view the oral cavity? Again, you can use four-handed dentistry or perhaps one of these devices. The Optrogate is nice because it's disposable. It's one and done. Usually pretty comfortable for most patients. I will say when sizing it, size up, especially if you have a more mature patient who has lost the elasticity in their lips and cheeks. You want a larger size, even if it's a tiny little, 5 foot, 100-pound woman. You want a larger size because there's less elasticity in her lips or cheeks, right? Comfort view, if you're more green, you don't want disposable, that is autoclavable, still accomplishes the same goal to be able to see the oral cavity better. ScanMate, really nice handheld device. It's autoclavable, would be very similar to a plastic mirror, right? You want something without reflection, so preferably not a metal mirror. Or you could use perhaps a tongue depressor. I like to put a finger cut or cut a finger off a glove and put it over the tongue depressor. Sometimes the wood can be abrasive to the patient's tissues. And then on the far right-hand side, that is by far my go-to, is some sort of a neo-dry dry angle and place that against the inside of the cheek so that you're capturing saliva from the parotid gland. What happens is when you retract the cheek, you milk that gland. And for some patients, it's like the floodgates are open and all of a sudden you have all the saliva and you're not really understanding like why or where it's coming from. So place a neo-dry against the inside of the cheek first. It will save you many a headache. Let's talk a little bit about best practices. So although every scanner has the capability, has software capability to tell you if you have enough occlusal reduction, it only tells you that at the end of your scanning experience. So you have to scan the operative arch, the opposing arch, and the bite registration before the software tells you if you have adequate occlusal reduction. At which time, it also has software that you can go in, you can erase part of the prep, the occlusal section of the prep, you can rescan, you can go back and reprep and then rescan that occlusal section. I'm just not a fan of it. I think it's introducing an opportunity for error when you're removing part of a prep, re-prepping it, and then rescanning it to count on all of those points of data merging together adequately. My suggestion to you is to make certain you have enough occlusal reduction before you ever take a physical analog or a digital impression. And your residents, for the most part, and or faculty, and I'm sure the faculty will agree that that's a basic gold standard in dentistry, right? And I'm not a fan of eyeballs, right? We all have them, and sometimes they work better than others, especially if it's a maxillary second molar. I'm going to be challenged to really see if I have enough occlusal reduction. So this is something called prep check, love prep check. You place it in the patient's mouth over the prep, have them bite. It's going to leave markings on the prep similar to articulation paper if there is not 1.5 millimeter of reduction in those areas, right? So then you go in with your burr, right where the markings are, and you're good to go. There is a cost associated to it, and I'm conscious and respectful of that. So take a piece of wax, right? Super economical, excuse me, and measure it with calipers to make certain that you have that 1.5 millimeter of reduction. That's a very easy go-to. Or a ball burnisher or a perioprobe that has a measurement tool to it that you can confirm you have enough reduction. So exposing the margin is going to be super, super important. And I like this slide because somebody called to my attention that the bicuspid, the distal of the bicuspid there, it really could have been smoothed off also. Totally agree. So it's nice when you see your restoration blown up on the screen larger than life and not just looking at it through your loops. So expose the margin so that you can see that finish line 360 degrees. And what would we use to accomplish that? I'm more old school, so I like a double cord technique where I will place perhaps a number 1 or a number 2 first, cut to the exact circumference of the prep itself. I'm sorry, a 00 first, cut to the exact circumference of the prep itself, followed by a number 1 or a number 2, whatever's needed to create that lateral expansion, retraction of the gingival tissue. That's what's super important. Lots of different cords out there. This is a Fisher cord packer from Ultradent. I wish I had stock in Ultradent. I don't. I should be a spokesperson for them because I really do like their products. And then Viscostat is their hemostatic agent. Love the fact it has a little sponge applicator and you can really burnish it right into the tissue. And I have used lots of different hemostatic agents across the country. They are not all equal. I will just tell you that right up front, not all equal. And then, I've experienced people will use like a little bit of peroxide, even superoxyl, and have had really good results. So there's lots of different ways to accomplish that. When using perhaps retraction paste or foam cord, which is really popular, it works nicely if you're placing it because you understand as dentist what you're doing. But if you're relying on your dental assistant, and I'm a dental assistant by nature, so I say this with respect, is they need to be educated on what the paste is doing. It's not just laying on top of the tissue to be a hemostatic agent. It is being expressed into the sulcus to expand that tissue. They need to understand that. And then it needs to have some sort of physical pressure, in my opinion, as well. So like a copper cap, even cutting a cotton roll in half and having the patient bite into it helps to control hemostasis as well as create that lateral retraction of the tissue. Now, here's why I don't like paste. Is sometimes you have to rinse so vigorously to remove all of the particles of the paste, and it will show up on your scan if you don't. And it's a distortion and the lab cannot use it. That you cause bleeding when you're rinsing really vigorously. So just be cautious of that if you choose to use paste. And can other techniques work? Laser, rotary curettage, not a fan. It causes a lot of bleeding. Electrosurge, it causes like little mountaintops of tissue that it's not smooth typically, right? So it can be difficult for the light of the scanner to look over those little particles of tissue that are left behind. And then recently I was working with an assistant who took blue mousse material and put it around her temp and then had the patient bite into that. That did a really nice job of retracting the gingival tissue. Nothing for hemostasis, but a really nice job for retracting tissue. So let's look at a couple different examples of scans. Right, so this is a good scan, good tissue retraction, and we can see a nice clear margin. We're really nice and clear. Again, making certain that not only are we looking at it in color, but that we're looking at it in monochrome or the stone model mode. Right, color and stone model. very nicely done. Not as crisp as the other, right? Let me back up one. So this is really nice and crisp, okay? But still good. Now, this one I think is really interesting because although at initial glance, I'm like, okay, this one looks good. But can we see this tissue tag on the distal buccal in the color? Maybe iffy, right? But when we shift it into monochrome, you can definitely see the tissue tag and lack of clarity on the margin itself. So that's a really good example of why you want to not only look at it in color, but look at it in monochromatic or stone model mode as well. These are some examples that I like to include that shows you what a bad scan is, what missing data is. So when you shift it to monochrome and you see missing data, like a hole, different scanners are going to show up in different colors. That is not going to be adequate. And the best way I can explain this is if you're thinking about analog dentistry, right? And you've got a bubble or a pole or did not capture the interproximal walls adjacent to that prep, you're going to retake the impression. Same thing with digital. There is a very small amount of cleanup that the laboratory can do, that AI can do to sort of auto-populate and fill holes. This is way too much. So this would not be acceptable. We would not be able to print a model or even model-free design this particular case. Another one that is deemed unsuccessful due to the missing data. Can we see the holes, right? Missing data here, like not going to be acceptable around the model or enabling us not to be able to print a model. This is a great example of retraction and isolation. So that lip needed retracted. It is now in the way. The tissue has sort of corrupted the scan of the scan body itself. Now, this one was one of my favorites when I was going through scans, looking for scans for this presentation, is that it was thought that that was adequate data for a valplast partial. It's like, yeah, no. Like you need the buccal vestibules, you need the palate. I mean, there just isn't enough information. Now, sometimes, and we refer to it as noise or scatter, sometimes you will see this on the screen. You will see it as well, and you're not really sure what's going on. At some point during your scan, most probably you have inadvertently scanned the tongue or the inside of the cheek or some maybe the patient swallowed and who knows what you inadvertently scanned. But it has now corrupted the scan. And it's important that that doesn't happen, right? So we want to retract the tissues as best as we can. And you can see lots of scatter here around these scan bodies, right? We want to avoid that, of course. Here's some examples of poor scans or unreadable margins, no clarity, right? No crisp to be able to design the crown, like, just not able to do it. Wouldn't even be able to guess on that. Let's talk a little bit about implants and a little bit about dentures as far as I know you all know what an implant is, but I want to touch on the critical areas as it relates to digital. So when scanning for an implant, you want to make certain that you are using a scan body, unless perhaps it is encode And with ENCODE, the healing abutment is the scan body all rolled into one. So that's the only case that you don't need a separate scan body. There will be more from additional implant manufacturers. They come out new every day. So there may be one or two out there that I'm not aware of yet. But in most all cases, you're going to need to pre-order a scan body. Excuse me. And that's going to be based off of the implant manufacturer. It's important to tell the lab what type of implant is in the bone, what type of scan body you're using, the platform size, and what type of material you want for that custom abutment, as well as the crown. And if the crown is going to be cement or screw retained. Now, before you start to scan, but after you place a scan body, it's critically important to take a radiograph to ensure that that scan body is fully seated. And that's like step number 2, right? First, you're going to place the scan body, and then you're going to take a radiograph. I have been chairside where we really thought that the scan body was placed appropriately, and then we take an x-ray and it's not. And that's your foundation. So it's super, super important to accomplish that. And every scan body is going to have some sort of a key identifier, a bevel, a divot, a dot, something. Try to place that buccally whenever possible. It's just easier for you to get to acquire that initial scan of the scan body and move forward from there. So a cement retained implant crown, a screw retained implant crown, and then let's talk a little bit about digital dentures. I mean, that's a whole animal in its own. However, we are able to successfully capture data, right? Capture data for dentures now that we were never able to do before. So typically we are going to be working with either a copy denture workflow, and a copy denture is when it's an exact copy of a denture that the patient has, that they walk in with, and they want an exact copy of that. Sometimes it could be like we could do a reline of that denture as well with a wash impression inside. Or this is the next one is a reference denture, and that's what we have had the greatest success with at NDX, and that is border molding and taking a wash impression in a patient's existing denture that meets certain requirements, and really think of it as using that existing denture as a custom tray. And then you can scan both the cameo of the denture as well as the intaglio where that impression material is. Next up is going to be an immediate denture. An immediate denture, everybody knows, right? The patient has some remaining dentition, which is usually pretty easy to scan for an immediate denture because they have existing dentition. Those are points of reference that all scanners are easily able to acquire. Remember though, like when going posteriorly, you want to capture hamular notch, you want to capture the post-palatine seal area, you know, where the post-dam would be, you need to capture the buccal vestibules, anything that you would capture in an analog impression, those anatomical landmarks, you want to make certain you're capturing digitally as well. And that's why the fully edentulous workflow is a little more challenging for most all scanners out there. So when scanning the fully edentulous patient intraorally, the acquisition of that data, you really do need to follow the specific recommendations from the scanner company as far as the scan path recommendations that they are providing for their particular device. So we talked about what we do primarily here at NDX. It's either going to be a reference denture that's taking a wash impression inside of it, really using that existing denture as a custom tray. a copy denture, which is an exact copy of an existing denture, or an immediate denture. I'm going to go through this part. I don't want to get too hung up here. So this is a visual, right, of what's acceptable for a digital denture, right? For a reference denture. So this denture would be used as the custom tray. So we've got the maxillary, we've got the mandibular. This is an example of that border molding, right? So we're not going to use like a green stick, but we're going to use a heavy body impression material just along the borders, place it in the patient's mouth, allow that to set, then remove it and take a light body wash impression inside of that. Then you're going to take the bite registration with it. So I like to put a little bit of, blue mousse or some sort of bite material on the occlusal surfaces of those dentures, because they do have a tendency to slide if you don't. So just put a couple little dots of bite material and then have the patient bite into place. Now, this is, then you're going to scan the bite registration. Instead of a wax try-in, what you are going to experience is something that we refer to as a functional try-in. It looks a little funky the first time you open the box, and it's just this white denture, right? It's like a A2 shade. It's nice because the patient can actually leave for a couple days and try it out, get validation from their loved ones that it looks good before coming back in and saying, yes, it's perfect. Or maybe there's not as much suction on the maxillary arch as you would like to see, and you could take a wash impression inside of that and ship it back to the lab, and then the lab can go to either another try-in or to a final. And then that's what that final scan of a real life case with the, not the scan, but the impression is going to look like inside that reference denture. Awesome. Thanks so much.
Oh, Kelly, thank you so much for sharing all this information. As you can see, Kelly has so much information to share, and there's so many nuggets of information to take away with you. And just one nugget of information that I took away from today is, I guess, Kelly, dentistry truly is in your blood. Having a dental lab in a house that you bought, unbelievable, incredible. But please reach out to us if there's any other information you want to learn about. Please let us know. We're here for you. See you all soon, everybody. Thank you. Bye-bye.
Take care.